get started. So for today's review session, we're going to start with the hepatobiliary system, and then I'll go through the study questions, we'll answer them together, and then what I'll do is I'll open it up for any general questions or questions that were on the study guides for the previous sections, okay? And what we'll do is we'll go back first to neurology, any questions on neurology, and then we'll do any questions on GI, okay? Okay, so liver questions. So the first one is actually a review prompt. So the question is, describe the gross anatomy of the liver and its blood flow. So blood flow into the liver, 2 vessels, right? What are those vessels? Portal vein, hepatic artery. Good. Portal vein, hepatic artery. And then hepatic artery is carrying what? Oxygenated blood. And then the portal vein is carrying blood that's coming from where? GI tract. Very good. So then that blood converges on the within the vessels of the liver, right? And then eventually the blood exits through what vessel? The hepatic vein that then drains into the vena cava. That's right. Okay? Good. And then stop me if you have a question about any of the questions I'm going through. Okay? Just raise your hand if I don't see you. And if I don't see you, call out. Okay, so the next question, what is an hepatic lobule and what is it composed of? So hepatic lobule is referring to a segment of the liver parenchyma, right? Of the liver tissue itself. Just bear with me because I'm using 2 different devices, one to record and one to project. It couldn't converge that. Okay, so the hepatic lobule was a segment of these hexagonal portions of liver parenchyma, right? And then the hepatic lobule has 3 main vessels on one end, and those vessels are branch of the artery, branch of the portal vein, and a branch of the bile duct, right? So the hepatic portal vein and hepatic artery are converging onto the lobule, and blood is mixing and flowing towards the center of the lobule, or the other end, where you have a branch of the hepatic vein. Okay? And so the blood coming in from the artery is providing oxygen and everything else that the cells need, and the blood coming from the portal vein is coming to the liver in order for the liver to accomplish all of its functions, right? It's detoxifying ammonia, any number of things, okay? So the liver cells that are forming bile, that bile is moving, remember, is moving in the opposite direction. And it's draining into that bile duct, and it's actually going to go leave the liver and go towards the GI tract. Okay? Make sense? Okay. So some basic liver anatomy. Okay, functions of the liver. What are the functions of the liver? So functions of the liver, we talked about them in the as being different categories, right? So we talked about functions of the liver falling into the category of energy metabolism, and that includes things like the handling of glucose, the production of glucose through gluconeogenesis or breaking down glycogen stores, cholesterol synthesis, triglyceride synthesis, the handling of amino acids, right? The liver also produces proteins, right? Produces all the plasma proteins. Most notable is the one that's most abundant, albumin, very good. Also notable are the clotting factors, right? Because that's something in the context of liver failure, we see a lot of bleeding issues. So it synthesizes lots of proteins, including a few hormones. The liver also does the job of turning fat-soluble substances into water-soluble substances, right? Biotransformation. And it does that through what's one of them that's going to end up in, one of the things that's going to end up in bile? Bilirubin, right? So it conjugates bilirubin, and then the majority of fat-soluble drugs are going to end up getting biotransformed by the liver to facilitate excretion. Okay. The liver also does things like producing binding proteins, right? That's important for the trafficking of hormones and other substances. The liver also takes up and stores vitamins like vitamin A, D, and B12 and folate. Okay. We talked about the protective functions like detoxifying ammonia, okay, synthesizing glutathione, which is this very critical antioxidant, clearing damaged cells and proteins and hormones and drugs, clearing bacteria, right, and antigens from the portal circulation. Okay, so the liver also plays a critical immune function. Okay. So I know there's a lot here, but is anybody confused about any of the functions of the liver? Yeah. Yeah, it's a, yes, yes. Yeah. Okay. So the question was, is biotransformation basically solubilization? And the answer is yes. Okay. Okay. So, next question. So next question is, what is portal hypertension? How does portal hypertension contribute to the development of complications like varices, encephalopathy, splenomegaly, and ascites? Okay. So if we're looking for a definition of portal hypertension, so hypertension we know is an elevated pressure. But this is an elevated pressure in a particular vessel. What's that? Portal vein, right? So it's an elevated pressure in the portal vein. And basically it goes from single digits to double digits, okay? So we're not talking about very high pressures, but it's still, it's supposed to be far lower than it is in the context of portal hypertension. So why does the pressure in the portal vein elevate? Fibrosis, right. So for our purposes, what we're looking at is portal hypertension as a result of cirrhosis, which is this chronic inflammatory process leading to the fibrosis of the liver. Okay? So once we get to this fibrotic liver stage, it basically impedes the blood flow through the liver. elevating the pressure. Okay. So we looked at, we talked about how when we elevate the pressure in the portal vein, it enhances blood flow to collateral vessels that actually allow for the blood to bypass the liver. Okay. So number one of the consequences is this increase in collateral circulation bypassing the liver. Now, which of the complications I mentioned is that going to contribute to? One more time. Okay, so it's going to contribute to all of them. But if the blood that's supposed to get detoxified by the liver doesn't get detoxified by the liver but enters general circulation, I think I'm hearing it, hepatic encephalopathy. Okay? So that bypassing of the liver means that the liver doesn't detoxify ammonia, right? And so ammonia gains access to the brain and it creates the encephalopathy. Okay? Now, I heard a lot of people say splenomegaly. Now, splenomegaly occurs because the blood usually moves from the spleen directly to the liver, right? Directly to the portal vein. So when you increase that pressure, okay, you actually impair the drainage of blood from the spleen. Okay? So basically the spleen engorges and it starts to sequester blood and blood elements as a result. Okay? Okay. Now, another consequence of portal hypertension is that it increases blood flow, or rather it impedes blood flow away from certain parts of the GI tract, okay, which causes what start off as very small veins, causes them to get engorged. Okay. So as a result of portal hypertension, these small veins associated with the GI tract, the pressure increases, blood doesn't leave those vessels as readily, and they get engorged. And what's the manifestation? Varices. And what location, where do we find these varices? Esophagus and the stomach, okay? Very commonly the lower portion of the esophagus, and then also we see them in the stomach as well. Okay? And then we're left with ascites. Okay. Now, portal hypertension contributes to ascites by increasing the capillary blood pressure within the mesentery, right? Enhancing that flow of fluid out into the peritoneum. But we know with ascites, what two conditions do we see ascites in? Well, you stole my thunder, but so we are narrowing in on hypoalbuminemia, right, as really being the primary causal factor in the development of ascites. But what two conditions do? Starvation and liver failure, right? So cirrhosis and starvation states, we tend to see ascites. And what they both share are hypoalbuminemia. Okay? The starvation because you're not consuming enough to produce proteins, your liver can't produce proteins, and then in liver failure because liver function has dropped. Okay. And then one other aspect of ascites that's important for us to mention is that as a consequence of this lack of albumin, right, what happens to the vascular fluid? It escapes the vascular space, right? So fluid starts to escape the vascular space because we don't have the oncotic pressure to keep it there. Okay. So it escapes into interstitial space and into this third space of the belly, okay, of the peritoneum. All right, good. Okay. So next question, which I may have already stolen from, but number 5. What are some of the factors that contribute to the net water and sodium retention seen in patients with ascites? We actually just mentioned it. So we have the low albumin, right, which causes plasma oncotic pressure to drop. Fluid escapes the vascular space. And what happens to blood pressure? Goes down. What organ in the body, kidneys, register that drop in blood pressure, and it reflexively activates the renin-angiotensin system, and so we start retaining water, sodium and water. Okay. And does that conservation of sodium and water lead to an expansion of plasma volume and a relief of blood pressure? No. Because whatever fluid is getting retained will quickly escape the vascular space. Okay? So the kidneys are always hearing this signal that we need more plasma volume. Okay? Good. So number 6, this is actually, you can tell how important I think this concept is because I've asked a couple of questions on it already. Number 6, how/why a patient in end-stage liver disease can have signs of fluid volume overload, edema, weight gain, etc., and hypotension. It's exactly what we just said. So they're going to, so we look at a patient to assess them for fluid volume overload. We look at things like whether there's pitting edema, right? We look at things like daily weights and a precipitous rise in weight, okay? But in a liver patient, all of those signs of fluid volume overload are not going to be accompanied by things like bounding pulses or bulging neck veins, right? Or elevated blood pressure. In fact, they're going to have low blood pressure because instead of that fluid volume overload being in the vascular space, it's in the extracellular, it's in the other compartments. It's in the interstitial and the transcellular space. Okay? Good. And it's all because of this drop in albumin. Okay, number 7. Describe the role of ammonia and Gaba in the development of hepatic encephalopathy. So let's put Gaba aside for a minute and just talk about ammonia. So ammonia is coming from where? It's coming from the GI tract, okay? And it's primarily coming from what in the GI tract? Protein. It's coming from proteins that are getting digested and turned into amino acids, and then the gut bacteria, right, consume some of that protein and release and produce ammonia as a byproduct. So that ammonia also gets absorbed along with the amino acids. And ammonia is neurotoxic, right? It's really bad for nervous tissue. So it normally gets into the liver, and the liver does what with it? Converts it to urea. Okay? So usually it detoxifies the ammonia. But it doesn't do that in the context of liver disease because, number one, liver function has declined, and we also have this bypassing of the liver, right? The circulatory bypass of the liver. So ammonia gains access to general circulation, it gains access to the brain, and it both changes the permeability of the blood-brain barrier and also tends to suppress brain function. Okay. And it manifests as encephalopathy. Now, what are some of the motor effects of encephalopathy? Flapping tremors, right? Good. How can we actually measure the changes in the brain caused by encephalopathy? The EEG. You'll actually be able to see a change in EEG output. And then, what is at its greatest severity? What does encephalopathy look like? Looks like coma. Okay. And so, how do we improve encephalopathy? Bring ammonia down. Okay, bring ammonia down. Now, we talked about the consumption of laxatives like lactulose, right? And lactulose is designed to speed up the rate of movement through the GI tract to decrease this production of ammonia. So if we looked at all the complications that we just talked about with liver disease, taking lactulose is aimed at reducing what? Ammonia and encephalopathy, right? Make sense? Okay. So there is also some theory. There are also some hypotheses connecting Gaba and hepatic encephalopathy. And so what that's based on, it's actually based on the knowledge of two things. Number one, if you, through the process of digestion, there is the release of lots of Gaba, some by the nerves in the GI tract. And then much of that GABA gets spilled over and enters the blood and goes to the liver. Okay. And normally gets eliminated by the liver. Okay. But again, just like ammonia, it gains access to general circulation in the brain. And in the brain, GABA is an inhibitory neurotransmitter. So it can reduce excitability, okay, which is the what it is thought to be doing in the brain. So if you look at a patient who is in a encephalopathic crisis, right? They're in the middle of a severe event. If you give them drugs that block GABA receptors, that will tend to actually improve their symptoms. Okay. So that's one of the thoughts behind what else could be contributing to encephalopathy. But it's kind of a complicated question or a complicated issue. Okay. But we know that ammonia is playing a key role. Okay. So Next question. Which forms of viral hepatitis are acute versus chronic, and do these two categories differ in their clinical time course? So they obviously differ in their clinical time course, right? Because what happens with acute hepatitis after you get that initial illness? You completely recover, right? You're able to totally clear the virus from your body. With the chronic forms of hepatitis, after that initial illness, you are not able to completely clear the virus, but you sort of get to this viral balance, this viral load that is under control to a certain degree, but persists in its activity. Okay. So, what are the forms of hepatitis that produce acute illness? A and E, and a very small percentage of patients who get B. Okay. Now, the rest of the patients who get B are going to have a chronic illness, okay, which may or may not lead to cirrhosis. But patients with what type of virus? All of them end up with chronic illness? C, right? And C is a very virulent virus and leads to cirrhosis almost guaranteed. Okay. And then which viral form did we not mention? D, right? And then so what does a person have to already have in order to get contract D? B, right? So hepatitis D, I wish they didn't rhyme because it makes it very difficult to say, but hepatitis D is actually a complication, right, of hepatitis B. And it is one of the causes of fulminant hepatitis, which is a form of acute liver failure, right? So it will potentially worsen a patient's prognosis if they contract D.
So would you classify that as either chronic or
I think it still remains chronic, but it now is a super infection. The D becomes a super infection. Yeah. Okay. Yes.
Is D cirrhotic?
Is D
cirrhosis?
Does D lead to cirrhosis? Yes. So D will increase the likelihood that the combination of the two viruses will lead to cirrhosis.
D is always, like, that's the consequence, right? Like, cirrhosis is always the consequence.
I can't with confidence say that getting D means that you're guaranteed to develop cirrhosis.
That's only for C.
Yeah. The hepatitis B is much more variable in its course in people. Yeah, and it actually seems to depend on how old they were when they got it as well. So age of exposure makes a difference. Okay. So the next question, what is cirrhosis and what morphological changes does it cause to the liver and why? So cirrhosis is a fibrotic liver disease, and it really represents liver failure. It's a form of chronic liver failure. Okay? And it is an irreversible process. Now, what morphological changes happen to the liver? So first of all, what's going to cause cirrhosis, whether it's viral or because of alcoholism or because of something else? What causes cirrhosis? chronic injury, chronic inflammation, okay? And very, very chronic injury and inflammation, because the liver is never getting a respite from the injury. So we were talking last time about how this is an organ where you cut a third off, it'll regrow, right? So if you injure the liver and give it enough time to heal, it will heal. But if there is never a respite from the injury, then what happens is chronic inflammation, right? Healing and injury at the same time. And what we end up with is this cirrhotic liver that, if I pull up a picture again, this cirrhotic liver now appears, instead of having a nice smooth surface, it now has this highly nodular surface. Sometimes those nodules are small, sometimes they're big. And if you look at the tissue histologically, what we see are these very thick and pervasive bands of fibrotic tissue separated by these nodules of actually regenerated liver. Okay, so the liver's still trying to recover, but it's so diseased that even the regenerated tissue is not able to recover the whole organ's function. Okay. And you can see how that fibrotic tissue wraps around those branches of the portal vein. You see that right there? It wraps around these branches of the portal vein and kind of tightens its grip around it, which is what causes that portal hypertension. Okay. So this chronic inflammation, this chronic injury that causes cirrhosis, what does it increase the risk for? Cancer. Hepatic carcinoma, that's right. So that chronic injury, that chronic inflammation, it is not uncommon to see the development of cancer cells in the or malignant cells in someone with cirrhosis. Okay. So number 10. What is the difference between alcoholic versus post-necrotic cirrhosis, and how do each go about damaging the liver? So post-necrotic cirrhosis is the form of cirrhosis that comes as a result of chronic injury through the hepatitis virus, okay, B or C, or B and D. Now, alcoholic cirrhosis is the form of cirrhosis that forms as a result of alcoholic hepatitis, okay? Chronic inflammation and injury as a result of chronic alcohol exposure. Now, the viral hepatitis, this is a virus, right? It prefers to replicate and reproduce in liver cells. Okay? And so it's replicating in these liver cells and triggering cell injury and triggering an inflammatory response. Okay? And eventually it's triggering cell death, and that is the hepatitis phase, that inflammation phase, right? That eventually leads to cirrhosis. With alcoholic hepatitis, the liver metabolizes alcohol, right? It metabolizes alcohol and it produces what? Acetaldehyde. Okay? So acetaldehyde is highly toxic to cells. Okay? especially liver cells. And it's also a known carcinogen, acetaldehyde. In fact, there's been recently some interesting data to come out of alcohol consumption, especially in women, and cancer risk. That your risk for all forms of cancer go up dramatically with even moderate drinking. It's super bad news, but it's especially important for people with like a family history of cancer to be aware of that risk. But this acetaldehyde, among other things, it's also interfering with the liver's ability to oxidize fatty acids, right? And so fat accumulates in the cells, leading to what? Fatty liver disease, which is a reversible stage, okay? Fatty liver disease will manifest as visual signs of fat accumulation and elevated liver enzymes. And it is reversible. But if it doesn't get, if the alcohol exposure doesn't subside, the alcoholic hepatitis will lead to cirrhosis. Okay. And then number 11 is asking about ALT and AST, alanine transaminase and aspartate transaminase, which are two of the transaminase enzymes that we find inside liver cells. Okay. And so if we do a blood analysis of looking for those enzymes, okay, because all cells in our body have a turnover rate, those enzymes are going to be present in the bloodstream. But if their levels rise, what does that suggest? Right. That means that we've got hepatocellular injury and death, right? Releasing those enzymes. Okay. So elevated liver enzymes are a good indicator of hepatocellular injury and death. Okay. So, general questions or further questions on the study guide questions let's just stay within the liver section for now, and then we'll switch gears to neuro and GI. Yeah. Yes. Yeah. So the questions about splenomegaly. I promised somebody who couldn't show up that I would say the questions because I'm not good at that. So the question is about splenomegaly and how it develops in the context of portal hypertension. So I may have said increased blood flow to the spleen, but the direction of blood flow is away from the spleen, right? It's out of the splenic vein and into the portal vein normally. Now, as the portal vein increases, and you can see, so blood is coming from the mesenteric veins, okay, coming from the splenic vein, and is destined to enter the portal vein. Now, with the portal hypertension, what that's going to do is decrease or impede the flow of blood away from those structures, right? Away from the GI tract, away from the spleen. And it's going to enhance blood flow through vessels that bypass the liver. So the splenomegaly is happening because you have blood coming into the spleen and then a reduced rate of blood leaving the spleen. Yes. Thank you for that question. Done with the liver, pretty much for now. All right. Okay, so why don't we switch gears and go to the neuro section, okay? All right. So neuro, I'm going to open up the neuro study guide too, just in case anybody would like that. Blah, blah, blah. There you go. So, questions about the neuro? So don't be shy. Do we feel comfortable with neuro? Is that why, or is it just that you're not sure what to ask? Yes. You should definitely still know that. Yeah. Muscular dystrophy, even though it's not on the study guide, it is content that you are expected to know. Yeah.
I think I screwed up my notes because on the slide it says that at one point I wrote ataxia and apraxia and alexia and neglect were not suggestive MS. And then at another point I wrote ataxia was, so I just...
So the question's about MS?
Yeah.
Okay. I don't know why this thing is really being weird. Okay. Blah, blah, blah. MS. Okay. Man. All right. I think somebody else asked me about this too. So you had, I think it might have been something that was written on was it something that you heard me say, or was it something you read on the slide?
On slide 38 you wrote that
38.
aphasia, apraxia. And I think I wrote ataxia was not, but I think maybe it is. But I lumped them all together.
No, ataxia will potentially be because they're going to have gait deficits, right?
Yeah.
They're going to have gait problems.
Okay.
So yes, so slide number 38, there's a line under the category of features not suggestive of MS. It says cortical deficits, meaning cognitive changes and intellectual function changes. Aphasia, apraxia, alexia, and neglect. These are less commonly associated with or not suggestive of multiple sclerosis. Yeah. Now, I'm remembering what somebody mentioned to me about, somebody emailed me. If you're in the room, please let me know. But they emailed me something about somewhere about the bowel and bladder function not being affected with MS. I'm not finding it here, but it can be affected with MS, bladder and bowel function. I'm not finding it here where it says it won't be, but it certainly can. 31. 31. Yeah, in muscular dystrophy, it definitely says that, and that's not affected with muscular dystrophy, because muscular dystrophy is not a neurological problem. It's a myopathy, right? It's a muscular problem. So bladder and bowel innervation are maintained, and you have less affected smooth muscles, less affected. So it's not, yeah, that's not going to be associated with it. Okay. Okay. Neuro questions?
Oh, I have one more question.
Go for it,
You
please.
don't have to answer it. Should we be memorizing the entire Glasgow Coma scale?
The question is, should you memorize the entire Glasgow Coma scale? The answer is no. Okay. And usually questions that start off as, should I memorize the entire, is usually no. Although there's certainly times where, you have to know something. But no, you don't have to memorize the scale. If I ever wanted you to, evaluate it, I would give you the scale, Yeah. Yeah.
Could you just quickly recap the different brain injuries, the different lobes and the associated personality changes that we would see or motor? Should we know that if you have epidural hematoma, that there might be the frontal lobe could have been affected, and then it would be motor?
Do you mean with stroke? I think you're talking about stroke. Stroke, yeah, okay. So the question's about different areas affected by stroke and the resultant problem or the manifestations. Okay, definitely. So with stroke, I'm just going to give a little bit of background before I. So with stroke, we know that we've got hemorrhagic stroke where there's bleeding in the brain. We know we've got thrombotic stroke where a clot originates in the brain, and then we've got embolic strokes where the clot actually originates not in the brain and travels, right? And then what's the most common place for those clots to form? On the left side of the heart, right? As a result of atrial fibrillation or some valve problem or something like that. And then lacunar strokes are a type of thrombotic stroke that affects smaller vessels that are more located more deeply within the brain, okay? So when we talk about classic stroke tends to include the thrombotic, embolic, and the lacunar. Okay, that's classic stroke. And it tends to have these common features, right, that we talked about: sudden onset, focal involvement, lack of rapid resolution, and a primarily vascular cause. Now, when we look at things that can be affected, right, functions that can be affected, you can have lots of functions affected depending on what vessel is occluded and what part of the brain has suffered ischemic damage. Okay, so we can have motor changes and sensory changes, and the motor changes are very, very common. And the most common motor changes are hemiparalysis or hemiparesis, where one side of the body has lost muscle control, either with or without loss of sensation. Okay. Facial drooping, right? Loss of arm and leg control. Now, the side of the body where you see the paralysis is the opposite side to where the injury is going to be, where the injury to the motor part of the brain is going to be. Now, strokes to the left side of the brain are much more likely to cause language problems because the vast majority of people, the left side is where you have that Wernicke's area, Broca's area, that the language circuit resides. Okay? It's not that those structures aren't on the other side, it's just that they're not the primary ones driving language. So most people will have that on the left side. And so if you have right-sided paralysis, and you can see how close the primary motor cortex on that left side is to like Broca's area. Okay, so having a stroke that impairs motor function on that side could easily also involve Broca's area, right? And so you have language problems as well. Okay. And I threw this up just to, please don't memorize slide 17 and 18, please. That it's not, the purpose was to give you something to be used as reference. But basically, it's the major branches where we see strokes happening, especially thrombotic strokes, and then dividing those vascular branches into anterior and posterior. We have sort of a incidence evaluation of like what changes we see, right? But basically, what we notice is that most of the motor and sensory deficits are caused by anterior strokes, right? And then things that like balance, vertigo, or changes in vision tend to be more posterior. Okay, and that's basically what I'm expecting you to have learned. Okay. So it is 2:20, so why don't we switch to GI, and we can always come back to neuro, okay, if we run out of GI questions. All right. Yes, ma'am.
I was just wondering if you had a breakdown of
In terms of like questions and sections, so I always tend to try to have the question makeup reflect what I have dedicated class time to. So since the GI and the neuro sections were longer than the liver, there's fewer liver questions than there are the other two. But I think there's probably about the same number of GI and neuro. Does that make sense? Yeah. So there was one neuro GI question that I'll answer right now. Somebody asked me before class, and I promised her if there was a lull, I would answer it. So the question was actually about distinguishing features, especially when it comes to signs and symptoms, between ulcerative colitis and Crohn's, okay, which is a great question. Now, there are lots of similarities between the two, but there aren't usually enough differences. So the reason why ulcerative colitis and Crohn's can be very difficult to differentiate is really because Crohn's disease often does also manifest in the colon. Okay? Ulcerative colitis only manifests in the colon. So with ulcerative colitis, you're essentially always going to have the same set of symptoms. You're always going to have, or signs and symptoms. You're always going to have these bouts of, repeated bouts of bloody diarrhea, okay, where the bowel movements are loose. The bowel movements usually have frank blood, right? And they tend to be frequent and small, right? Small in volume. And sometimes they're actually lacking stool. It's just sort of mucus and blood. Okay. With ulcerative colitis, you're going to have abdominal bloating, abdominal pain, okay? And it's going to be a reoccurring problem. You're going to have times of relapses or exacerbations followed by remissions. Okay. And then so basically with ulcerative colitis, it's not really going to vary much in terms of how it's going to present. Okay, it's going to present as colitis. Okay. With Crohn's disease, because Crohn's can happen anywhere, and because Crohn's can happen anywhere, it's much more variable how it can present. But for people who have what we call Crohn's colitis, where the Crohn's is isolated to the colon, that's going to be difficult to differentiate, potentially difficult to differentiate between ulcerative colitis and Crohn's, okay? Until you do a colonoscopy, because once you visualize the colon, it should be very easy to tell the difference. What are the ulcers going to look like in ulcerative colitis? Shallow and continuous. And with Crohn's, they're going to be deep and patchy, right? So if you visualize, it should be very easy to tell the difference. With Crohn's, you may have this. You may actually have the same manifestations as you see. Okay? You can have the bloody diarrhea, the frequent small bowel movements, the pain, right, with the Crohn's colitis. But you're not, on average, the blood loss and the blood in the stool is going to be less in Crohn's than it will be with ulcerative colitis. And it may even be microscopic amounts of blood. And you need to do that, that guaiac test to actually determine if there's blood in there. And then, so does that make sense? So then if you're looking at Crohn's, that is not only in the colon, now you're looking at manifestations that you will never see in ulcerative colitis. Okay? You'll see things like ulcers in the mouth, right? You'll see ulcers in the small intestine, especially in the ileocecum. You will find strictures, right, where the loop of bowel will narrow and become very small. Okay, and potentially you can see some nutritional deficits if the ulcers are found in the upper part of the small intestine, especially in the duodenal area, even though it's less common for them to be present there. And in terms of more serious complications, ulcerative colitis and Crohn's tend to have tend to manifest differently, right? So ulcerative colitis, you worry about how much blood loss there is, okay? That the person may become anemic or they may need a transfusion. And you worry about things like toxic megacolon, right? Obstruction of the colon because of a weakening and a dilation of the colon wall. And we also are concerned with perforations. Okay. And with Crohn's, the complications that we worry about are things like malabsorption, perianal disease, systemic symptoms, and fistulas. Okay. Yes, ma'am.
Slide 16 from GI, can you just briefly go over the enteric nervous system is short versus the long loop?
Yes. So the question is slide 16. Oh, yeah, that's a good one. Slide 16, talking about the enteric nervous system, the autonomic nervous system, and this long loop, short loop idea. Okay, so what we're talking about here is control over gut function. Okay, what are the players involved in controlling gut function? So, in terms of the targets, okay, in terms of the targets, what we're talking about is the control of the smooth muscle in the gut, which controls motility, the exocrine glands, which control the production of digestive juices and enzymes, and the endocrine cells, which control the production of GI hormones. Okay? Now, when we talk about the short loop, what we're talking about is, so any loop, any control loop has a sensor, right, and an effector. So any control loop, you have to have something sensing the presence of changes, and then something that's going to do something about it. Okay? Now, in the short loop, the sensors and the effectors are all within the GI tract. The entire loop is present within the GI tract, okay, which is why we call it short. And the short loop involves either the enteric nervous system or the enteric endocrine system, right? The network of cells that can release hormones. So the enteric nervous system is it's a hardwired control. Right? So we have sensors that can sense things like the presence of fat, right? The presence of distension. And then we have nerves within the enteric nervous system that can affect smooth muscle, exocrine cells, and endocrine cells based on what they're sensing. Okay? So an example, we consume food, okay? That food hits our stomach, and then the enteric nervous system notices the presence of distension, just anything. It notices the presence of protein, okay? And then it reflexively increases motility and secretion of the stomach juices. So that's short loop that involves the enteric nervous system. Those endocrine cells in our stomach also participate in a small loop, right? We talked about those D cells in the antrum. They sense the presence of acid, and when the acid drops, they release what hormone? Somatostatin. That's designed to reduce acid production. Okay? Short loop. But this time it's an endocrine short loop. So these endocrine and nervous short loops are constantly running. And then on top of those short loops, we've got a long loop that involves the brain. Okay? And this long loop that involves the brain is not as important as the short loops. But this long loop can manipulate anything. Okay? So the long loop of the brain has its own arm directly into the GI tract. Through what nerve? The vagus nerve. Okay? So that's the brain's own personal arm into the GI tract. And there are sympathetic nerves as well. That's kind of the same thing. And then the brain also can influence the function of the enteric nervous system and those endocrine cells. Okay? It's a little like the dean can call me up and say, teach them about the brain or whatever. Okay? So the brain can actually affect gut function by working through those other short loop systems. Does that make a little more sense? Okay. I know it's actually a lot of abstract concepts, but when you think about the process of digestion, you actually will take it for granted that that's what's going on, you know. So how are we feeling? Are we feeling prepared? Sort of? Yes, ma'am. You want me to go over the enzymes in slide 36 of the GI? Yeah. Okay. So slide 36. Okay, so this is the brush border enzymes, right? So these are the enzymes that are found attached to the plasma membrane of the cells that line the small intestine. Okay? And it just so happens that those cells have these microvilli that somebody thought looked like bristles of a brush, okay? Which is why we call them brush border. And there are two types of enzymes that we find on the brush border. We find disaccharidases, okay? Enzymes that break down the disaccharides, which include maltose, sucrose, and lactose. Okay? Maltose is basically two glucose molecules attached to each other. Sucrose is a glucose and a fructose, and lactose is a glucose and a galactose. Okay? So those enzymes break down those disaccharides and release, they liberate the monosaccharides, and then they enter the cell and get absorbed. Okay? And the other category of, or the other type of brush border enzyme is the Amino Peptidase, which is a proteolytic enzyme that breaks down smaller polypeptide fragments. And that liberates the amino acids that are then absorbed. So we've got brush border enzymes that are dedicated to disaccharides, which is a carbohydrate, amino acid, proteins. What category of food what category of food don't we have a brush border enzyme for? Fats, right? We don't have a brush border lipase. Lipase comes from pretty much one source, and that's the good old pancreas. Yes, exactly. Did anybody look over the practice case studies this weekend, maybe? Yeah? Was there any that you had particular difficulty with or that you struggled with? Okay, let's, please.
There was that slide on gastric bypass.
Yes.
And so it like bypasses the duodenum, right?
Yes, it does.
Is there just no, like the absorption that would normally happen there, does that not happen at all?
It's a good question. So the question is about the gastric bypass study, case study, and the fact that the gastric bypass actually, food entirely bypasses the duodenum. And so the things that normally get absorbed in the duodenum, are they just not getting absorbed? So it's a very good question because you have a greatly reduced capacity to absorb the things that normally get absorbed in the duodenum when you bypass it. But it's actually why that portion, the bypassed portion, remains in the abdomen and stays attached, because you will still get bile secretion, you will still get lipase secretion. You just now have a much smaller window and opportunity to absorb that fat. Okay, so that's the situation with the fat. But that actually is a goal, right, of the bypass surgery, is to actually reduce your capacity to break down and absorb fat. Now, there are other things that get absorbed at the duodenum that's much more that are entirely problematic, and that's things like calcium and iron, okay, fat-soluble vitamins, things like that. Now, we do still see calcium, iron, and other vitamins absorbed in the ileum and also to a certain extent in the colon. And so the thought is that your body will compensate, but it's actually the vitamin deficiencies are very, very common with bypass surgery, and so people are actually sign papers that they promise to take a multivitamin every day, right? Because that overloads the system with what you're trying to get, right? Because if your absorptive capacity is reduced, you really need to provide a lot to compensate. And if you get evaluated and find that you have a vitamin deficiency, you need to get supplemented. So it's in one way, bypassing the duodenum and missing out is the purpose, because that's where fat is broken down and digested. But on the other hand, there are problems with it. Yes, ma'am. Do you often see steatorrhea in patients with bypass surgery? Patients with bypass surgery are advised, especially in the beginning, to have a very narrow diet, which is going to have a very low fat content because they still haven't, adapted to their new GI tract. And there is a complication called dumping syndrome, where things just go straight through because you haven't stuck to the diet. So if the person is consuming too much fat in the beginning after surgery, you can very likely see some things like steatorrhea. But if they're following the recommended diet, there's there's less of a likelihood for that. Yeah. I'm actually doing a little bit of a talk later this week about addiction as part of it, alcoholism as part of this talk, and I actually came across some interesting statistics about how prevalent alcoholism post gastric bypass surgery is, and they call it like this isn't on the test, by the way, but I think they call it like addiction transfer or something. So it's like the primary like food addictive quality of whatever's going on is not addressed through the surgery. It is supposed to be addressed through other channels, but if it's not, you're at high risk to just transfer your addiction to a different addiction. So it's an interesting thing. So why don't we call it a wrap for the big session? If anybody wants to stay after and pick my brain, I'm happy to do that, okay? Thanks for coming, guys. I appreciate it.